Rheumatoid arthritis. So what is rheumatoid arthritis? It is a chronic inflammatory autoimmune disease primarily affecting the synovial joint but also have an extra-articular manifestation. The clinical course of the exaggeration and the remission occur in the rheumatoid arthritis. Epidemiology. Its prevalence is 0.8 to 1% in the Europe and Indian subcontinent. Female to male ratio of 3:1, highest prevalence in the Paima Indians, that is 5%. Now discuss the pathophysiology of the rheumatoid arthritis. In the pathogenesis, there may be an environmental trigger or the genetic predisposition. These environmental trigger and the genetic predisposition modifies the host protein and converted them into the immunogenic. These immunogenic proteins are then presented to the dendritic cells or the antigen presenting cells such as macrophages, and these dendritic cells then present the antigen to the T cells and B cells. B cells and the T cells become activated. These B cells become plasma cells, produces autoantibodies, and then immune complexes are formed, resulting into the vasculitis. And these activated T cells then secrete the tumor necrosis factor alpha and interferon gamma, activate the macrophages. These macrophages then releases certain cytokines. These cytokines then activate the fibroblasts. These fibroblasts again release certain factors and can lead to the cartilage breakdown, or these fibroblasts can also release prostaglandins, and the nitric oxide causes pain vasodilation. So basically, in the short, there in the pathophysiology, there are environmental factors and the genetic factors that converted the host proteins into a certain proteins that become immunogenic, and these immunogenic proteins then presented by the antigen presenting cells to the T cells and the B cells. These T and B cells can lead to the immune response from, and which can cause certain conditions in our body such as acute phase proteins levels raise, cartilage breakdown, bone erosion, vasculitis, and pain vasodilation. Moving toward the clinical feature, the patient present with the joint pains that improves with the activity, joint stiffness that is mainly the early morning, having that time period of greater than 20 minutes. Joint swelling may be present, ulnar deviation of the fingers, swan neck deformity of the fingers, that deformity of the thumb, and cock up toe deformity may be present in the patient presenting with rheumatoid arthritis. In these pictures, you will see the ulnar deviation of the fingers. The fingers is deviated towards the ulna, and in the below picture you will see the swan neck deformity. Basically, the swan neck deformity is the flexion extension of the fingers at the phalanges. Now discuss the diagnostic criteria of the rheumatoid arthritis. The criteria that are included in the rheumatoid arthritis are the joint affective, serology, duration of the symptoms, and the acute phase reactant. Joint affected, if there is one joint affect, we will give the score 0. If the large joint 2 to 10 are affected, then the score 1 is given. If 1 to 3 small joints are affected, the score is given 2. And if 4 to 10 small joints are affected, the score is given 3. Greater than 10 joints, at least one small joint is affected, the score is given 5. In the serology, there are two factors, rheumatoid factors and the ACPA. If they are negative, the score is given 0. And if they are low positive, the score is given 2. And if they are high positive, the score is given 3. If the patient of the rheumatoid arthritis is less than 6 weeks duration of the symptoms, the score is given 0. And if it have greater than 6 week duration of the symptoms, then it is given the score 1. In the acute phase reactant, if the CRP and ES are normal, the score is 0, and if they are abnormal, the score is 1. Patients with a score greater than 6 or equal to the 6 are considered to have definite rheumatoid arthritis. Basically, in the systemic, the patient may present with a fever, weight loss, fatigue, susceptibility to the infection. There may be a muscle wasting, bursitis, tenosynovitis, osteoporosis. The patient may have anemia. The anemia may be due to the anemia of the chronic disease. Gut loss anemia due to the excessive use of the NSAIDs in the treatment of the rheumatoid arthritis. There may be a thrombocytosis or the eosinophilia. In the lymphatics, there may be a Felty syndrome and the splenomegaly. These Felty syndrome, basically the complex triad of the rheumatoid arthritis, seropositive rheumatoid arthritis, thrombocytopenia, neutropenia, and the splenomegaly. There may be a nodules in the extensor spaces. These nodules may convert into the sinuses and the fistula. In the ocular, there may be episcleritis, scleritis, scleromalacia, and the keratoconjunctivitis sicca. In vasculitis, there may be a digital arthritis, ulcer, pyoderma granulosum, mononeuritis multiplex, and the vesical arthritis. In the cardiac, the patient may present with the pericarditis, myocarditis, endocarditis, conduction defects, coronary vasculitis, and the granulomatous aortitis. In the pulmonary, there may be a pulmonary nodules, pulmonary fibrosis, pleural effusion, bronchiolitis, Kaplan syndrome, bronchiectasis, and pneumothorax. The Kaplan syndrome is the complex of rheumatoid arthritis and the carbon deposition in the lungs. In the neurological, there may be a compression cord compression, cervical cord compression, compression neuropathy, peripheral neuropathy, mononeuritis multiplex, and there may be amyloidosis which mainly affect the kidney and can lead to the lupus nephropathy, which is the main cause of the death in the rheumatoid arthritis. Now moving toward the investigations. To establish the diagnosis, we will fill the clinical criteria, ESR and the C-reactive protein, which mainly show there is the inflammation in the body. Ultrasound, X-ray, MRI of the affected area, rheumatoid factors, and the anti-citrullinated peptide antibody may be present. If the patient of the rheumatoid arthritis have negative rheumatoid factor, it is the seronegative rheumatoid arthritis. To monitor the disease activity and the drug efficiency, we will fill the criteria of pain, early morning stiffness, joint tenderness, joint swelling, DAS28, ESR, and the C-reactive protein. To monitor the disease damage, we will do the X-ray and the functional assessment. To monitor the drug safety, we will do the urine analysis, CBC, chest X-ray, urea, and the keratin and the LFTs. Now, what is DAS28? The DAS28 is the disease activity score 28. We will calculate the swollen joint, tender joints, measure ESR or the C-reactive protein, note patient global health assessment, and this is the website where there is a calculator. We will enter the data into this calculator and we have given the DAS activity score 28. If the DAS activity score 28 is greater than 5.1, it is high active rheumatoid arthritis. If it is between 3.2 to 5.1, it is moderate active rheumatoid arthritis, and if it is 2.6 to 3.2, low disease activity rheumatoid arthritis, and if the DAS activity disease activity score 28 is less than 2.6, there may be a remission. Now management. In the management, we will do the pharmacological management, non-pharmacological management, and the surgery may be indicated. Non-pharmacological treatment include physiotherapists and the occupational therapists that basically tell us about various exercises. And in the surgery, we will do the joint replacement, synovectomy, excision of the metatarsal head, neurosurgery. Now discuss the pharmacological management of the rheumatoid arthritis. In the screen, you will see the algorithm for the management of the rheumatoid arthritis. After diagnosis the rheumatoid arthritis, we initiate with methotrexate and the prednisolone. These doses are adjusted within the 6 weeks, and after 6 weeks we will give the DAS28 scoring. If the DAS28 scoring is less than 3.2, which show the low active rheumatoid arthritis, we will continue with the methotrexate alone. And if the DAS28 scoring is greater than 3.2, we will add sulfasalazine and HCQ. After that, we again do the DAS28 to find out how the drugs are going to act on the body. If the DAS28 scoring is less than 3.2, which show the low active rheumatoid arthritis disease are going to work on the drugs are going to work on the body, we will continue with the agents like methotrexate, sulfasalazine, and HCQ, which are given before. And if the DAS28 scoring indicate 3.2 to 5.1 score, we will consider subcutaneous methotrexate or different C DMARDs. Thus, after that, we will again do the DAS28. If the DAS28 is less than 3.2, we will continue the therapy, and if it is greater than 3.2, we will add biologics or the target sensitive DMARDs. After sulfasalazine and HCQ added, we will, if the DAS score is greater than 5.1, add biologics or the target sensitive DMARDs. After that, we will again do the DAS28 scoring. The DAS28 scoring less than 3.2 indicate that the drugs are going to work on the disease. We will continue the therapy, and if it is greater than 3.2, we will consider change to different biologics or the target sensitive DMARDs. Now discuss the rheumatoid arthritis in pregnancy. In pregnancy, the immunological changes may occur, and many patients with the rheumatoid arthritis go into the remission during pregnancy. In the conception, the methotrexate should be discontinued for greater than 3 months, or lefonamide discontinue for greater than 24 months before trying to conceive. And the paracetamol is the oral analgesics of the choice during pregnancy. Non-steroid anti-inflammatory drugs, NSAIDs, and the COX inhibitors can be used from implantation to 20 weeks gestation. Glucocorticoids may be used to control the disease flare, but it can lead to the hypertension, glucose intolerance, and the infection. DMARDs that may be used include sulfasalazine, azithromycin, hydroxychloroquine, and DMARDs that must be avoided include methotrexate, lifoxamide, cyclophosphamide, and mycophenolate. Biologics therapy is expensive, but it is safe during pregnancy. The main risk in immunosuppression in neonate, except for the sertolizumab, which does not process the placenta in the appreciable amount. Breastfeeding. If there is breastfeeding, we will discourage the methotrexate, lifoxamide, and cyclophosphamide in the patient of rheumatoid arthritis. So basically, in the rheumatoid arthritis in the pregnancy, we will consider paracetamol, NSAIDs, and COX-2 inhibitors. The glucocorticoids may also be indicated, but we have to work up with its complications. And the DMARDs that cannot be used are the sulfasalazine, azithromycin, and hydroxychloroquine. They are used. And the DMARDs that must be avoided are the methotrexate, lifoxamide, cyclophosphamide, and mycophenolate. Follow me to get more informative videos.